instruction course. It's on decoding itching and watering in different scenario. Itching and watering is a very common symptoms what we get in our regular OPD, and we are trying to cover all the spectrum of patients, those who present with itching and watering to our general OPD, starting from the refractive surgery, from cataract surgery, in pediatric age group, in adults, and also in systemic diseases. First, I would like to call Dr. Umesh. Yeah. He will talk on blurring stopped, worrying continues following refractive surgery.
Good morning, everybody, and welcome to AIOS2025. Thank you.
1 minute. Slide.
Thank you, Dr. Mallikarjun, for carrying out this instruction course and quite a few topics of interest, especially for practice management. Most of us see these problems day in and day out, and I think it is prudent enough on us to go ahead and find what is the pathology, etiology, pathology, and also management options available. Refractive surgery, yes, I'm sure most of us who are doing refractive surgery see this one. The refractive surgery is the most performed surgery in this world right now, and it is very satisfying both for the patient and the doctor, especially the outcomes. But even though the anatomical success is very high, we see quite a few number of patients complaining of either blurring or some other complaint, especially asthenopic or dryness complaints. And that is when they come to the OP, we all feel that why you have got 6/6 vision, you are reading 6/6, why are you still complaining? So that is one thing that most of us feel as surgeons, but we need to take their complaints and also understand what is the possible causes. What are the possible non-refractive causes of refractive surgeries? Mainly dry eye, of course glare and halos. There are temporary visual disturbances, basically binocular vision anomalies, non-strabismic binocular vision anomalies. So what happens actually when the refractive surgery is done is there is the nerve plexus is cut, corneal nerve plexus is cut, which causes neuropathic keratopathy, dry eye, and most of them complain of these symptoms, irritation. It could be combination or it could be one of these: irritation, burning, foreign body sensation, and tearing. And this tearing is actually very problematic. We feel that they are dry eye and they are complaining of tearing. So that is where we have to be careful in assessing, along with fluctuations in vision. The fluctuation vision, very classical. The patient is reading 6/6, you get a 0 on AR and your retinoscopy, but still they're complaining of fluctuations in the vision. The more severe, very rarely you see hyposthesia, that is delay in corneal epithelializations, sometimes very rarely neurotropic ulcers also. So I think it is, we must understand what is the anatomy of the basal plexus, that is the stromal vessels. They enter to the stroma, mid-stroma, and lose their myelin after entering 1 millimeters, and then go up perpendicularly, pierce the Bowman's, and becomes the subbasal plexus. And these three are very important: the stromal, the subbasal, and the subbowman's plexus, nerve plexus. And these subbasal plexus end up as nerve terminals, which perceive the different mechanical or chemical perceptions. So what happens post-refractive surgery? The LASIK, what it does is it transects the subbasal fibers, and the stromal ablation damages the stromal fibers. So both in LASIK, both the subbasal fibers nerves is gone, and also the stromal ablation causes the stromal nerves also is cut. In PRK and SMILE, theoretically, only the stromal nerve is affected because the subbasal nerve plexus is preserved. And that is what you see at the confocal microscopy here. In post-operative 1 year, the LASIK recovery is late, whereas the PRK and SMILE recover much faster, and hence theoretically they give lesser dry eye symptoms. The etiology, of course, is postoperative inflammatory response. The production of MM6, interleukin, nerve growth factors, all these things. Damage to conjunctival goblet cells, especially surprisingly, the femtosuction causes more damage than the mechanical suction. And the change in corneal curvature, obviously, flattening causes instability of the tear milim, blink reflex, and the ocular surface, lacrimal gland, neuronal reflex is lost. The incidence ranges from 36 to 75%, this dry eye. The PROWL study, that is the patient reported outcome study, there is a PROWL 1, PROWL 2. PROWL 1 was done on US Navy people, and PROWL 2 was done for the normal citizens. It showed that 1/3 patients, approximately 1/3 of all post-LASIK, did suffer from dry eye, and of which 4 of them had very severe symptoms. I believe that this is the 4% whom all of us have to cater to. And usually the symptoms peak during the first week and recovers in 6 to 12 months time, depending on the various factors we'll discuss later. And approximately, this is a very big range, 8 to 48 different studies are showing that it will be affected up to 6 months post-LASIK. However, in post-PRK, the 37 patients complained dry eye symptoms after PRK. The risk factors for the dry eye are, preoperative risk factors are the preoperative dry eye. That is why assessing dry eye is very important. Higher the power, higher the chance of dry eye, obviously, because more ablation depth, more stromal cut, and you will get more chances of dry eye. Contact lens users, yes, because of the ocular surface inflammation, long-term inflammation. Females, older age, are more prone. Compared to Caucasians and Asians, Asians do have a more propensity for dry eye. These are the risk factors. Surgery-related factors, surgical technique, we saw PRK, SMILE, theoretically they should get lesser compared to femto or mechanical LASIK. Stromal ablation, the 6 mm zone, more the chances. Hyperopic ablation, because the periphery, the plexus are more. So hyperopic ablation causes more dryness than flap diameter. Yes, the lesser the diameter, the more diameter you get. Thickness of the flap. Previously, we all used to do 130, 140. Now most of us are doing 90, 100. So that way, to some extent, it has come down. But otherwise, that definitely matters. And the hinge position. The bigger the hinge position, the more chance of dryness. The smaller hinge position. Superior versus nasal. Nasal, possibly the fact is the long ciliary plexus at the nasal are preserved. So there they say that the dryness is much lesser. Many studies are there. Many studies right from 2000 up to 2022, from early 2000. Most of them, I am just showing all the studies just to show that consistently right from 2000, irrespective of the changes in the refractive surgeries, we are seeing that somewhere around 27 to 30, 1/3, 30 to 40% is the dryness, irrespective whether they had pre-operative, post-operative, and most of them return to normal after 6 months, within 6 months. Very few went on to have these symptoms for up to 4 to 6 months. This is 27 study, 27.5%. The 2015 study, they returned to normal for up to 3 to 6 months. This 2000 study, 20%. So most of them are well within the 1/3 what was earlier described. And this is 2001 study showed 41%, 14%. So somewhere 20 to 40% is the average, and if you do your homework well, maybe you could reduce that. The management, yes, tear supplements, you have a gamut of tear supplements available in the market, and most of them are doing well. The polyethylene glycol and polyvinyl alcohol, PVC, and PVA and PEG, they said it was better, but when compared with hyaluronic acid, they said it was similar efficacy. Most of them are all more or less the same, but CMC with hyaluronic acid did a better job. So people who complain more, maybe this combination could do better. So CMC with high A was better than CMC alone. Cyclosporine as a prophylactic did not show any effect, but that was way back in 2013, and they used 0.05%. Now we have the 0.09% Sequa drops. We don't know what is the newer, whether prophylactic will help or not, but we are using in some cases. But definitely those who had preoperative dry eye, cyclosporine did help in the long term. Since I don't have any this one on the experience on this, but they say that it improves mucin and also dry eye, and that is the diaquophosphol tetrasodium. Autologous serum in very severe dry eye, both plasma rich platelets and autologous serum did help. That you can keep in mind. And punctal plugs, yes, it does help. That all these things you should keep in mind in patients. There will be 4 to 5% of patients who will keep complaining to you. You do this, most of them will be comfortable. One more. Shall I continue?
I can continue.
Okay. It's not moving.
One more minute.
Okay. The other things is glare and halos. Glare and halos are yes, significant, again related to dry eye, and most of them subside within the first 3 months. Very rare. And for those who are significantly, we have used brimalol, and that definitely gives some help. Rainbow glare, classically in post-femto, that was because of the on the surface, back surface of that, and that also reduced. Especially this was very visible in the early stage where the higher energy and low hertz was used. Now the hertz resistance has increased, is feeling better. This one study which did was persistent post-operative pain. This also they did in after refractive surgery, and surprisingly this was there, and this percentage 11% was the same that occurred even in general surgery patients like hernia and hysterectomy patients. So mostly somewhere the persistent pain is related to these things. And non-strabismus binocular vision elements, nowadays we are seeing a lot of asthenopic symptoms because most of them are having a lot of screen time. So now as part of it we are doing binocular therapy for patients complaining post-operatively, and we are getting very good results. This is a couple of studies done by All India where they did find significant changes in the initial, but especially in the AC by A ratio, stereo acuity, and all these things. But most of them came back to normal within 6 months, even stereo acuity also. I think to conclude, laser refractive surgery is very safe, very effective, very high satisfaction indexes. Most effects are transient. With good understanding of symptoms and adequate care, we can give them, and most important here is reassurance, and that is one which takes us to manage these patients. Thank you.
Thank you, sir. Thank you for the insights. We come across these sort of patients in everyday practice. And now we call upon Dr. Mallikarjun sir, who will be speaking on challenges in managing those with all started since the time of surgery in post-operative patients.
Okay, to start with, I had an experience last around 15 days back. We have an emergency phone number in our hospital where the patient has any post-op emergency, they call. So one patient called and he told to our nurse that I have severe itching, something is going in my eye. I had to, so they gave an emergency appointment, and he was supposed to come to our OPD. I was thinking, well, what would have happened to the patient? Maybe somewhere I did a wrong surgery, or something happened to the IOL. But when a patient came and examined, he had a simple MGD. So that is the importance and critical thing about this dry eye or MGD after post-op cataract surgery. Dry eye, especially MGD, is the most common cause for itching and redness following cataract surgery. The symptoms may be very temporary, but they are very annoying to the patient and very annoying to the operating surgeon also. And the prevalence of dry eyes following cataract surgery varies between 10% to 57%. That was the studies have been shown. and they are more symptomatic after 3 to 4 weeks. They won't complain immediately after cataract surgery, but they complain after 3 to 4 weeks. Why it happens? So why it happens, especially after cataract surgery? Because we use a lot of medications. They contain all the preservatives like BAK, and they cause epithelial toxicity, and there would be a meibomian gland dysfunction. And in SICS, we do a conjunctival peritomy. This destroys the goblet cells and reduces the mucin secretion. This leads to the dry eye. And when you do a more corneal entry and a bigger corneal section, that denerves the corneal nerves, that would also cause a dry eye. And if there is a more exposure time to the microscope, that also leads to the dry eye. So you have to practice doing surgery a little bit faster. And one more important, which we don't give importance, is the lid speculum. The special applied on the lids by the speculum. So if you apply more and if you retract it more, and it will obliterate the structures of the meibomian glands. That can also lead to post-op MGD. Following cataract surgery, there will be more inflammatory cells, and that leads to meibomian gland dropouts and leads to meibomian gland dysfunction. And we also have found out that the dry eye is more common in MSICS, that is SICS, than phacoemulsification. This was a study done in our hospital, and most commonly seen in women because of their menopausal age or hormonal changes. And this can happen without pre-existing MGD. That we have to keep in mind, because pre-operatively you would have done all the investigations, correct examination, but still it can happen after cataract surgery. Other risk factors include diabetes mellitus, autoimmune disorders, and use of antihypertensive drugs, because nowadays most of the people are becoming hypertensive, and even in the age of 40s, 50s, they are on the antihypertensive. This also leads to dry eye. And antihistaminics, antidepressants, thyroid malfunction, and hormone replacement therapy, all these are the risk factors for the dry eye. This is all the science. But what actually patient thinks is, we have to deal with different minds and different patients, because what they think, the IOL is scratching in my eye, the IOL is tilted. This is all my experience I'm telling. And surgery has not been performed properly. My nerves have been cut. And these patients, I think, who are doing cataract surgery, they would have had this experience. And so they keep on coming. They come on for 1 month and you give some drops, and again they come on 2 months. So we need to counsel them properly. And best thing is, you have to examine them fully. Don't neglect them. Just do. We know it is something dry eye or something, and don't do a quick examination and give some drops and send them. You have to talk to them nicely, and you have to examine properly and do some investigations. Then tell them there is nothing wrong, and then they will be happy. And these subtle signs you can see in the slit lamp examination. There will be enlarged meibomian glands, something meibominuria, there's more secretion of the meibomian gland, and capping of the meibomian gland. These are all the indications of MGD. Whenever I see the patients, I know that the patient has some amount of dry eye. First thing I tell them, your IOL has been fixed perfectly. Before telling anything else, I tell them your IOL is correctly fixed. Then the 50% of their apprehensions will come down. Because they think is only because they would have paid for, especially you do a premium IOL, they would have paid for that money. They always think of this is something wrong with the IOL. Even it holds good for even uneducated or even some IAS officer, anybody. They always think in terms of intraocular lens. And some investigation you can do. There would be some less the tear film height would be less, and that you can grade them. According to that, you can plan your treatment. And your routine OPD, you can do a Shermer's test and T-BUT. There we can differentiate between whether it's aqueous deficiency or evaporative dry eye. And fluorescent staining can with you in the interpupillary area, there will be staining. And rose Bengal staining also will give in interpretable area because it stains on the devitalized cells, and we can see a stain on the conjunctiva as well. And in more symptomatic patients, you can use a autorefractor. Everybody has the autorefractor, and you take a picture and you can assess the meibomian glands. So sometimes you will see a good meibomian sign. Sometimes you see a good number of drop-offs of the meibomian glands. Based on that, you can assess, and also it will help us to manage the patient. Management is again counseling the patient and also giving teardrops. CMC works well in aqueous deficiency, and sodium hyaluronate works well in evaporative dry eye. And you can also give a Trialose. It causes deeper hydration, protects against oxidative insults. And in severe cases, you can add cyclosporine or tacrolimus. One most important thing I always tell the patient is lid hygiene and warm compresses and lid massage. This is a very simple technique and it works very well. And you have to give a very good instruction to them because they should know how to do it. So they have to apply this warm cotton on the lid at least for 2 minutes. They close the eyes, apply it for 2 minutes, and massage with the finger placing horizontally for the upper lid from up to down, and for the lower lid lower to down, because that's how the meibomian glands are situated. They are vertical. So when you apply pressure like this, whatever the secretions are accumulated, they would come out. So I always show this video to them and teach them, and it works well. And in severe cases, we can try a punctum plus. There are temporary punctum plugs like collagen material available, and permanent silicone type of punctum plugs are available. That can also be used. And other most likely causes for dry eye is conjunctiva callosis, which we usually try to miss. It's a redundant conjunctiva, which is usually seen below the lower limbus, and this carefully you have to examine. And treatment is very simple. You can add a teardrop if it is less symptomatic, and if they are very symptomatic, you can do a simple excision of the conjunctiva. You have to mark pre-operatively where is the callosis, and under topical anesthesia, you can just lift it and cut it. And if it is a large one, you can put a small amniotic membrane. Or if it is a small one, you can just cut it and leave it. This will work. See, this is a large one, so I placed an amniotic membrane over there. This would definitely reduce the symptoms of the patients. And pterygium is also one of the causes if you operate only the cataract and leaving behind the pterygium, because of the presence of pterygium, there will be worsening of the ocular inflammation that will lead to dry eye. It can be treated with topical steroids and lubricants. And concretions that we sometimes miss, and that you have to lift the upper lid and see if there are any concretions, remove them, and you can add them with the teardrops. Watering following cataracts is common because we give nowadays we give a lot of medications following cataracts. That medication itself can cause the punctum stenosis. Treatment includes a course of steroids and punctum dilatation. This you can do in your OPD, or if it is a very small punctum, you can put a perforated plugs or like mini Monaca. Thank you.
Thank you for the wonderful talk, sir. Now we call upon Dr. Harshita, who will be speaking on I am not only in the eye, systemic diseases associated with itching and watering.
Thank you, ma'am. So I would like to discuss a few systemic causes of watering and itching that we see in our routine OPD. So not always the watering and itching that we notice may be related to the eye. I would like to discuss a few cases. So we had one patient who came with complaints of redness and pain in the left eye on and off since 6 months, associated with headache on the left side. He has been to multiple hospitals before, and every time he got treated with topical steroids, antibiotics, but he says that his symptoms kept recurring after stopping the medication. He had no other systemic complaints. So upon examining, the visual acuity was 6/6 N6 in both the eyes, and the intraocular pressure was also normal. The right eye examination was unremarkable. Coming to the left eye, we noticed a significant scleral and episcleral congestion in all the quadrants, more in the temporal and the superior quadrant. The fundus examination was normal. Thus, we made a diagnosis of left eye recurrent anterior diffuse scleritis. Topically, the patient was started on prednisolone acetate eye drops, and he was also referred to the rheumatologist for adequate systemic workup. Upon examining, they found that the patient's ANA profile was positive, as well as the quantiferon gold came positive. So they started the patient on anti-tubercular therapy and systemic prednisolone tablets, and topical prednisolone was continued with slow tapering doses. After about 3 months, the scleral congestion had reduced, but mild episcleral congestion persisted. Patient was also started on immunomodulator therapy, low dose methotrexate initially. At present, the patient has completed 9 months of anti-tubercular therapy, and he has been using methotrexate and tacrolimus systemically. And the patient now is in remission of scleritis since 12 months on routine 2-monthly follow-up, and has not been using any topical therapy since 1 year. Since it has been a year since the patient is in remission, the tapering of immunomodulator therapy has been started. Thus, various systemic diseases can present with very subtle signs first to the ophthalmologist. While examining, we should also be careful to look for some other systemic indicators which can direct us into thinking that maybe the patient has an underlying autoimmune condition, and we should send them at the correct time to the rheumatologist for further evaluation. So we had another case of a 40-year-old male who came with complaints of redness, severe pain, watering in the right eye since 1 month with worsening since a week. The patient gives history of similar symptoms 6 months ago, which resolved on taking treatment, and he has history of joint pains. So coming to the examination, in the right eye, we see that inferiorly there is a 2 mm crescentric area of significant thinning from 4 o'clock to 8 o'clock position with active infiltrates and vascularization. Rest examination was okay, and in the left eye also there was 2 clock hours of minimum thinning in the temporal peripheral cornea. Sorry, I don't have the picture. Systemically, upon examining, the patient was on wheelchair due to lower lid deformity, and also in the hands we can see ulnar deviation of the hands along with swarm neck deformities. So topically we suspected peripheral ulcerative keratitis, started prednisolone and moxifloxacin eye drops, took the patient up for conjunctival resection, and also referred him to the rheumatologist, who found that the RA factor was positive. Along with our topical therapy and surgical therapy, the patient was on systemic methotrexate, folic acid and prednisolone tablets. Now the patient is on regular follow-up. There is no recurrence of symptoms since past 1 year. We can see that in the image that there is infiltrates have completely resolved. The patient is doing much better, and even his systemic symptoms are under control. Some other options that we have for very significant PUK with impending perforation can be cyanoacrylate glue with BCL, Tennant's patch graft, amniotic membrane, corneal patch graft, or even lamellar or penetrating keratoplasty in severe conditions. Thus, a combination of topical therapy like preservative-free lubricants, collagenase inhibitor, steroids, immunosuppressants, cycloplegics, antibiotics, along with adequate systemic therapy like immunosuppressants or corticosteroids, or if you are suspecting infective etiology, then antibiotics is important. If we do, both should be done together so that the patient's condition can be adequately resolved and there will be no recurrence noted. Coming to another case where a 53-year-old female suddenly came with complaints of severe redness and watering in the left eye since 2 days. The patient gave a history of undergoing pterygium surgery in that eye 10 days ago. Systemically, the patient was a known hypertensive and gave few episodes of respiratory infection in the past 2 years. No other significant history was elicited. Coming to the ocular examination, the right eye was within normal limits. In the left eye, cornea, we could notice a scar where the pterygium was excised, and a melted conjunctival graft was seen with focal necrotic scleral tissue and significant congestion surrounding that area at the site of pterygium excision. So we made a diagnosis of left eye surgically induced necrotizing scleritis and started the patient on topical prednisolone as well as ofloxacin, but also we sent the patient for a rheumatologist opinion. Upon examining the patient, C ANCA had come positive, and they diagnosed the patient with Wegener's granulomatosis or granulomatosis with polyangiitis and started systemic prednisolone and cyclophosphamide in tapering doses. The patient was on regular follow-up with us as well as the rheumatologist. At 3 months follow-up, we can see there is significant improvement. There is infiltrates have resolved, the necrosis has arrested, congestion has also reduced significantly. The patient is doing well now. The average life expectancy of a patient with Wegener's granulomatosis without any treatment is 5 months, with a 1-year survival rate of less than 20%. More than 80% of treated patients have recently survived for at least about 8 to 10 years after diagnosis. Thus, since or surgically induced necrotizing scleritis may not always be related to the surgery, we must suspect that there may be an underlying systemic condition, and we should do a detailed evaluation to prevent such dreadful complication and manage it in time. Thus, I would like to conclude by saying that patients with multiple systemic diseases may first present to the ophthalmologist with some simple complaints of watering and itching, and they may often even be misdiagnosed as conjunctivitis or blepharitis. We should always have a high index of suspicion. Along with ocular, we should also look at the various systemic signs that the patient is presenting, so that we can refer them to the correct doctor at the correct time, and the patient can get proper treatment for the same. Thank you.
Thank you, Harshita. And if you have any questions, we'll take at the end of all the talks. Now I'd like to call Dr. Pallavi Joshi. She'll be talking on managing the known and grown in adults and old age.
Not this.
What?
Good morning, everybody. Thank you, Dr. Malik sir, for including me in this IC. So what I would be now speaking for the next 10-12 minutes will be about basically a roadmap of approaching patients who have itching and watering in the adults and old age. So that's why we have put it as a known and grown. So itching and watering symptoms are the most commonest which we see in our daily practice. There is no doubt about it. But they are having varied as well as overlapping symptoms. Means same person may have different etiologies. And understanding this is very important for two things. One, because it allows us to find out what the patient has, and unless we don't know what it is, the treatment will not be fine. So this is volume.
Yeah, what exactly do you feel?
I feel the itching,
Okay,
watering,
okay.
pain, that's what.
Are you using medications?
Yes,
Are they helping you, sir?
little bit.
Little bit.
Yes.
Okay.
Actually 12 days back she gave me cysteine and acute. So I'm applying that. So after that little bit, that is not completely cured.
Yeah, so as you can hear this, I'm sure every one of you have seen. Patient gives a detailed explanation of watering, itching, irritation, medicine you have taken, but not happy. So let's see why basically this is. So let's unbox this itching, watering in the adults. I cannot cover everything, so these 4 most important things we'll be covering. One is the ocular allergy, chronic conjunctivitis, drug-induced eye problems, and last but not least, the blepharitis. So we all are aware that ocular allergy is basically an allergic keratoconjunctivitis, which is a collection of diseases which have mainly allergic origin. And it can be mild, transient, but it can also be very severe. Second is it affects, allergic conjunctivitis affects the whole of the lid, right from lid, conjunctiva, cornea, tear film, everything gets affected. And it has a multifactorial immune mechanism. usually prognosis is fine, but the patients can, if not treated properly or improper treatment, can lead to inflammation and even vision threatening complications. So simplest classification, we know clinical classification as seasonal, perennial, atopic keratoconjunctivitis and vernal. If you go a little bit in detail, this again can be divided into IgE dependent and IgE independent, or IgE and something else. So if you see, the seasonal and perennial are purely IgE acute occurrence, whereas the vernal, AK and the contact dermatitis have both IgE as well as the T cell mediated. Why do we need to know this? Because whatever we use is all because why it occurs. So if you see this pathway, it is multifactorial. One, majority of allergies have epigenetic phenomena. There is also inflammation, there is an inciting factor, and the combination of adaptive and innate immunity which are taking place. So we know that in this case, as I said, in case of seasonal or perennial, it is purely Ig mediated, eosinophils are there, degranulation occurs, and we treat them symptomatically. But it is not as simple in case of the VKC and in the case of AKC, where T cell mediated reactions occur. And last but not least, the most important principle we all know is that ocular allergy can actually create a milieu for dryness. So patient will say, I have itching also, watering also, but he also has dryness. And this is something we should understand, because the allergy affects the lid, it produces meibomian gland disease, allergy damages the goblet cell, it damages the stability of tear film, and it also affects some amount of scarring, producing aqueous deficiency. So all these three affect the allergy. So all of us know that VKC is usually in children, but we have adult VKC, which is usually seen in 10% of patients who come to us in clinical practice. There are two types of adult VKC. One which has actually started as a child, but normally we say ki puberty ke baad it will settle. But these are the ones in whom it doesn't. And there's one more in which we call late onset VKC, which occurs after puberty. So this is a adult VKC. So what are the features of this? These most important are the 6 things. When you see an adult VKC, usually here we all know that in males it is more common, in children, whereas in adult it is not having that kind of this. Second, there is no family history. Third thing is they don't have any systemic allergies also. Because we see in children sometimes they have either rhinitis, asthma, something. But the adult VKCs don't have this. And the adult VKC is a longer duration and requires more treatment. And there is a lot of androgen overexpression, hence it is more visually threatening. So how do we see what is most important different here is you see usually higher incidence of subconjunctival fibrosis in these patients. They will not have corneal ulcers like shield ulcers, what you see in children, and usually tarsal thinning. So here you can see that they have more lid issues rather than the limbal issues. But
You can continue.
okay.
Continue.
And also they have the presence of limbal stem cell deficiency. So these are a few pictures of the adult VKC pigmentation, and you can see this is a chronic sequel. You can see nice pearls of conjunctival cysts which are there, because indicating of basically it is a chronic inflammation that's occurring. And the quality indicator has been assessed, and these adult patients are the ones who are very much disturbed as compared to children, and the most commonest complication is itching. So what are the challenges in management of an adult? We can see is mainly like any other principle. My next speaker will be covering this in the children's this, so I will not be this. We know this is the bag we all have. Anti-allergics are there, steroids are there, topical lubricants are there. We also have the immune modulators as well as systemic therapy. But this everybody knows. What is most important is how do we deal with this? So a new recent study came which came based on evidence that how do we treat these allergies in adults. So this study basically gives this spectrum in which mild, moderate, severe as per the presentation, how do we approach. Now what has happened from conventional to what has happened here is the use of immune modulators has been earlier. Before we used to try with antihistaminics, we used to give steroids, but an understanding that, as I said, the immunology shows that there is a T cell mediated pathology. So immune modulators come in a lot early, and that helps in taking care. Second change is we are now moving slowly in case of redundant cases to go for systemic immunotherapy. So a paper by Gokhale et al. Have reported that in very severe form of VKCs, use of cyclosporin systemically also tends to reverse. So don't hesitate to use systemic immunomodulators, but in accordance with a rheumatologist. And this can save the eyes rather than wait for things to go bad. Next one is atopic keratoconjunctivitis, which we all know is associated with skin or dermatitis. So these patients will usually be having it coming anytime when they have the dermatitis in their body. What is important in this we should know is that patients who have atopic dermatitis, 95% of them will be the ones who are having the eye involvement, whereas all dermatitis may not have. So what I am trying to bring home here is, if somebody has atopic keratitis, then they definitely will be having dermatitis, and the reverse may not be true. So referral to a dermatologist is good. So here what is the difference is, this is a telltale sign. Typically you see this is the pigmentation more inferior. Everything in atopy is inferior, whereas in VKC it is more up. So this is a typical pigmentation which we can see. And we know that in case of AKC it is more severe and it affects the cornea more. Why? Because pathophysiologically here in case of AKC patients there is release of some substance called as gelatinase, which causes the damage to the cornea, limbal cells damage, and causes vascularization. So this is the typical, you might have seen such patients who come and say, yahan pe khujli hota hai. This is the panda eye, which you can see there is periocular pigmentation and the Denny Morgan fold because of release of the tear film. This is, or you can see there is presence of corneal involvement. Whenever you see allergy, papillae and corneal involvement which is not in the upper part like a shield ulcer, please understand it may be an atopic keratoconjunctivitis. They can go to this kind of a condition, and this is the worst form of this when they come to you after many years. I treated here, I treated there. This is because it was a missed atopy. Classically you see that the lid is very thickened up, meibomian gland disease, total LSCD, and there you are seeing something called cicatrization. Atopic patients have scarring, which you will never see in patients with vernal. So we have to always look for this, just move the lid down. This can go if left untreated. So treatment for atopic keratoconjunctivitis is the same in mild and moderate. What is most important I want to is, in refractive AKC, you have to start them on oral immunomodulators like cyclosporin, or nowadays also this drug which is the biologicals. We know we have infliximab, rituximab, but this drug, that is the omalizumab, which is actually a IgE antibody, is found to be very effective. These patients actually who are not responding to anything can go with these medications under an allergy specialist treatment. Severe forms of it can be brought under control, then we treat them with topical or other systemic immune modulators like MMF, or they can go for azathioprine. What I'm trying to draw here is AKC, when it becomes severe, it has to be treated with systemic immunomodulators. So another interesting thing which I came across is, the dermatologists have found that there is a gut dystrophy. Means if gut microbes are bad, then the skin diseases are getting exacerbated. So even now there are few studies where they have started using this lactobacillus enterogerminum, which we give as the probiotics, found to reduce their dermatitis. So this is something new which even probably may help the AKC. Last but not least, sir, I'll take 2 more minutes, sir.
Yeah.
This is something which skin prick test. I'm sure somebody must have told you that everybody does skin prick tests, and they say about immunotherapy. Two most important things I want you all to take from this is, skin prick test is a standard test for identification of sensitization, and giving immunotherapy means desensitizing the patient can be only done if then the skin prick test a specific IgA mediated allergy is there. Otherwise it may not act. And there were 3 types which you all know. People used to give oral immunotherapy, but the fear was anaphylaxis, and also there was subcutaneous, which was very cumbersome. But nowadays we use something called as sublingual immunotherapy, which is actually very comfortable and less reaction, but it has to be taken at least for 1 to 2 years. Most important aspect of slit is, usually sometimes in the first 6 months they may have acute exacerbation of the previous allergy. So slit has a role, but it has to be more defined in case of eye allergies also. Contact dermatitis, we all are aware, it is when it comes in contact with the skin. This occurs with almost all the AGMs that we are aware about, and most commonest being the ones which have preservatives. Just to show you, this typical sago grains you're seeing, I'm sure you must have seen them in all patients. These are the follicular reactions because of chronic preservative containing AGMs, as well as AGMs themselves produce this. The simplest here is, in such cases we have to use preservative free AGMs and patients respond well. Just see this patient, she was with this kind of a picture using chronic AGM for past 6 months, was not ready to leave because she thought she'll lose her eye. And just after 10 days of stopping it, it has absolutely recovered. So please be mindful of seeing if it is persistently happening, what could be the cause. Last but not least, this is another picture of cicatrizing conjunctivitis. This is something, is a big spectrum. What is it is when you treat the patient with even lubricants as well as you treat them with steroids, patient is being refractive, then please look at, are you missing something called cicatrizing conjunctivitis. It is a rare disease, but it is one commonest reason where patient keeps coming back. I don't know, I am not happy. आँख में खुजली है, पानी आ रहा है. This is the most commonest where you have to look and check for typically whether there is presence of medial punctal stenosis, and usually typical cicatrizations are starting on the medial aspect. Causes are many, but to say the most commonest we tend to see is again atopy, and second sometimes is the ocular cicatrizing pemphigoid, and the most commonest being drug-induced pemphigoid, that is pseudopemphigoid because of chronic use of medications. How do you treat them is most important, give chair time. These are those patients you have to take detailed history, and if you find that there is presence of cicatrization, this is a patient after treatment, the previous patient, so they respond well. We need to take the biopsy of the conjunctiva and send it for identification, and also do immunofluorescence to rule out any autoimmune disorder. If autoimmune disorder is negative, then assume that it is more of an inflammatory. Last but not least, I am sure all of us have seen the eyes, but we are so focused on the cornea, a little on the lens and the pupil, we forget the lid. But Demodex blepharitis is known to occur. It is usually seen in 50 to 70 years of age group people, caused by a mite. Patients complain of lot of itching and erythema. Very troubling for the patient. The classic sign is, what you can see here is you see greasy cylinder-like crust along the lid. If you can see this thing here. So, patient lid, if you are seeing a cylindric trough with greasy thing, please pick it up and see it under the microscope. You can see the mite moving. So if you pick such a thing, please, it has to be treated, and it has to be treated in a different way. So what are the treatment modalities? Most of us use the tree oil, or we can use ivermectin and metronidazole, topical or systemic. A new drug is come, which is under the phase 3 trial called lotinalair, which is a drop format, but lid hygiene is very important. And one more small clinical nugget here is, if the blepharitis is there, you have to pick up this. Sometimes it may not be a mite, but it can be a lice. So these two, blepharitis also are the things which see in the older age group where we can. Last but not least is the angular blepharitis. We all see the macerations which we actually tend to miss. This usually occurs because of either staphylococcus, or classically we have been taught as the moraxella. And treatment is usually erythromycin, or you can also treat any emulant, will be okay in this case. So to conclude, itching and watering can be of various etiology in the grown-up. Please understand, and this can be that allergic disease, both AKC and adult VKC, is very underestimated. We think it may be just patient is complaining unless we look for it. Third is we need to treat them with dryness. And last but not least, chronic conjunctivitis is actually a window to a disease in the body. Please don't miss it. If you see cicatrization, punctal stenosis, please go a little more further in investigating. So last but not least, if patient is persistently complaining of any itch, we need to watch it. Thank you.
Thank you, Dr. Pallavi, for that elaborative talk. Now I'd like to call Dr. Rupashri. She is going to talk on itching and watering in pediatric age group.
Good morning all. I thank Malik sir for giving me this opportunity, and also the AIOS. Most of the things are covered by the previous speakers, and I am going to cover a little bit more about the allergic conjunctivitis, mainly in children, and along with that other differential diagnosis we have to look for. There is a proverb which goes like this: no matter how many times you do it, you are always going to have an itch to do that again. That is the, if there is an itch, there has to be itch. That is the richest. Itching and watering of eyes in children, we are all commonly encountering in our clinical practice, and especially in pediatric age groups, kids will not complain of rubbing of eyes. We have to ask the parents whether they rub the eye, or how many times a day, what time of the day, and whether it is intermittent or chronic. All these questions we have to ask from the parents. And many a times father will be accompanying, and he will not be knowing most of the things, and only the caretaker, the mother or somebody else in the family who is there with the child will be knowing. Please extract that history. And the differential diagnoses are many, and the previous speaker told it may be blepharitis or some infectious or non-infectious conjunctivitis or keratitis. Why we have to worry about this itching and watering in these little children is, as we all talked about, it affects most of the children, nearly 50%. Imagine half of the pediatric population, they will be having itching eyes. And often it is underreported, leading to underestimated incidence and prevalence, and accompanies allergic rhinitis, and it's a notable comorbidity of asthma. Parents will be more worried about the rhinitis and the asthma, and when the eye symptoms become severe, they tend to come to the ophthalmologist. There is considerable impact on the patient's quality of life and comfort. For the children, the concern is corneal involvement may result in visual decline, and for the parents, it's a substantial burden on the economy through the healthcare costs and the reduction in the productivity. As we are all aware of, a lot of global warming and more carbon dioxide in the environment and the changing botanical landscapes, which is making the peak pollen season increasing. It's so increased that the peak pollen period is sometimes all through the year. What classically is described in the VKC as classification of seasonal, perennial, vernal and all, we are seeing all the time in the year because of these peak pollen seasons. And data scarcity from large-scale industries in these allergic conjunctivitis is remaining a challenge for accurate assessment and understanding of this condition, which is multifactorial and it is very difficult to understand. This I am not going to speak about because Madam has already spoke about it. And the etiopathogenesis, as we all know, the mast cell degranulation and the production of IgE, this we have to note because we are going to test in the investigation part about the serum IgE levels and the TR-IgE levels. It is produced more of locally, and only in chronic cases it is seen in the serum. Coming to brief about a little bit different allergic conjunctivitis in children, the seasonal. This is the typical look of a allergic conjunctivitis child who will have little bit watering and perilimbal pigmentation and nicely opening the eye. The most common form it is, and pollen is the most common cause, which is there outdoor, and it's very often associated with rhinitis, and the cardinal symptoms signs described are tearing, itching, redness and edema. These four will be there in all allergic conjunctivitis in children. And relapse occurs regularly at the same time of the year, and lids will be usually normal. Child will be, that's why I told it will be normally opening the eye. Follicles and papillae may be present. The second one is perennial allergic conjunctivitis. Most of the symptoms last longer than 6 weeks. We are seeing nowadays longer than this period. And outdoor allergens, that is animal dander and house dust mites, are the most common cause. And usually only the conjunctiva will be involved. And sometimes in some cases we can see the corneal involvement in the form of SPKs. And in addition to these classical symptoms, note there may be lid edema. And most serious cases can have corneal involvement. Coming to vernal keratoconjunctivitis, if it's only the conjunctival involvement, we need not worry much. But if it is involving the cornea, it can cause threat to the vision. It's a severe form of allergic conjunctivitis. In children, it affects boys more than girls, and first appears before the age of 10 years. And photophobia sometimes causes blepharospasm. All these are seen in the corneal involvement. And there will be disabling pruritus. The child will be rubbing the eye intensely in the class, in the outdoors, in the home, even during sleeping. That's what the mother says. And many a times the children in the hostel, the parents will not be knowing how severe the itching is. We have to assess depending on the signs. It affects the quality of life, and many a times from the school the children will be sent back saying that you get the cure for this condition and then bring the child back to the school. How to describe that there is no cure for this? It's very difficult to counsel the patients. It generally regresses at puberty. This is a very difficult question to answer to the parents because they'll be asking how many times we have to visit to the hospital and how many times we have to buy the medications and how long my child will suffer with this disease. It's very difficult to counsel. It takes some time to understand them, to make them understand the disease pathology and its course. Certain cases can evolve into atopic keratoconjunctivitis. See, the early phase reactions will cause some symptoms, but in the late phase reactions, it's very toxic to the corneal epithelium, and conjunctival fibrosis is seen in some chronic cases along with SPK, shield ulcer, vernal plaque, which can threaten the vision. These are some pictures wherein the typical perilimbal pigmentation and limbal papillae are seen in these children, and sometimes in chronic cases when the allergy comes down, there will be some large limbal papillae with some prominent vessels, which many times will be confusing with the OSSN. And lower tarsal conjunctiva and also the upper tarsal conjunctiva has to be examined. That is equally important in all the cases, though the children will not be very cooperative for slit lamp examination. In chronic cases, some limbal thickening as seen here, they will have extreme photophobia. It's very difficult to take the clinical pictures like this in those children. There will be some cobblestone papillae, Horner Trunter dots, and lot of discharge in between the papillae and also the canthus. These children, the socioeconomic status also will be very low, and the parents and the children will not be concerned about the discharge and the hygiene, ocular hygiene. Atopic keratoconjunctivitis, as madam has explained, I will skip this, and some corneal complications like pannus can be managed, but shield ulcer, if it becomes grade 2 and 3, very difficult. And keratoconus we all are aware of, and every child has to undergo corneal topography as a routine ocular examination in every annual visit. In our hospital, we follow this protocol. Whatever the K reading is, whatever the topography is, the last year we do them. And limbal stem cell deficiency in chronic cases. Many differential diagnoses to this simple allergic conjunctivitis, and we all know how to differentiate them. And dry eyes, madam has talked about. Toxic conjunctivitis will be usually unilateral and sometimes bilateral, and there will be some inciting agent which we have to ask for the detailed history. And rosacea keratitis is intermittent and sometimes chronic, and not have any classical clinical pictures. We have to keep it in mind. And scleritis can have pain and glaucoma also. Flectinular conjunctivitis is also sometimes confusing because it causes a inflammatory nodule in the conjunctiva, and if the cornea is involved, there will be a small ulcerated lesion with a trailing leash of blood vessels. Management in the investigation part in these little children, it's very difficult to go for the invasive test, but the skin prick test is considered as gold standard. But the tear film, tear total IG and serum IG and eosinophil levels are done in these cases. The importance of it, we have to know which cases we have to ask for these tests is in seasonal and perennial allergic conjunctivitis, tear total IgE will be positive, and in VKC, total serum IgE levels are also very high, and serum specific antigen IgE test is also positive. Coming to the management, educate your patient very well. It takes a lot of time to counsel them and understand the disease, and ask the mother to control, avoid eye rubbing, and tell them how important the hygiene is. And slowly the children also should learn through the mother. Cold compression, very difficult because the children will not stay in one place, and avoid allergen exposure. And again, the difficult part because they always want to play outside, and plano glasses will definitely help. We prescribe them routinely for all the school going children who understand that wearing this glass prevents them rubbing from rubbing the eye. And we have to tell the parents and the school teacher also that child should wear the glasses all through the class. And the management algorithm for seasonal and perennial goes like this, which is already discussed about. Only thing is there are large numbers of antihistamines, mast cell stabilizers, and dual acting agents. In a nutshell, we can tell that most commonly used cromolans, sodium chromoglycate and olopatadine, and nowadays many other antihistaminics. Definitely sodium chromoglycate takes some time, some 6 weeks time to have the effect on the disease. So olopatadine is definitely helpful in acute cases, but for the maintenance, sodium chromoglycate will be better. It has to be given 4 times a day. And olopatadine, different concentrations are available, starting from 1 time a day to 2 times and 4 times. And dual acting agents, in the newer agents, bipotastine, the drug is very effective in rhinoconjunctivitis, where the child will have the allergic rhinitis and the conjunctivitis also. Topical steroids, as we all know, we have to monitor the IOP and see for the cataract. and topical antibiotics in these cases because the hygiene will be poor to prevent the secondary bacterial infections. As we all know, cyclosporin and tacrolimus are the steroid sparing agents, and there are a lot of studies, and both tacrolimus and cyclosporin have equal potential to be used as first line drugs in vernal keratoconjunctivitis. And supratarsal steroids, again, in very little children it's very difficult, and can be given under sedation, and otherwise it can be given under local anesthesia. TR tacrolimus levels were studied, which drug is better, and all both are equally effective, and improvement was seen in tacrolimus patients, and it has proven its bioavailability in the TRs, and it's a very effective alternative method. And these are some potential advances in the allergic conjunctivitis. Many are not yet available in the market. They are all in the research process. And surgical management of sequelae, I am not going to cover in detail. If there are giant papillae which are disturbing the ocular tears film, then they can be excised, and mind it, we have to give it for the histopathology. And SLET for LSED, symblepharon release, and AMT for the symblephrons and occlusions in the secondary dry eyes. In the shield ulcer, as we all know, in the Cameron grading, in the grade 1, just the medical management with the prolonged use of topical steroids with the monitoring of IOP will be helpful. And in grade 2, it definitely requires debridement and AMT, and in the grade 3 also the same. And the pediatric dry eye disease, as it's all covered by the previous speaker, we all have to know vitamin A deficiency. Though there are some national programs for the vitamin A supplementation, we have to keep in mind there are still people who are living in the remote areas, they can have this. And lifestyle modifications, this has to be counseled properly to the parents. And we have to treat like adult dry eye disease in the same way. And chronic blepharoconjunctivitis, previous speaker has covered a lot about it. And rosacea keratitis, as I discussed earlier, it's very difficult because there will be no classical signs, but we have to see for the corneal vascularization and meibomial gland thickening, lid margin thickening and telangiectasias. There are some stepladder management for this. Azithromycin and erythromycin ointments are used in these cases. Marginal keratitis, they very commonly seen in the children, where we have to look for it. Some small corneal infiltrates with a lucid interval and corneal neovascularization has to be treated with mild steroids. And coming to the last epidemic, keratoconjunctivitis, if it is involving the cornea, some things like subepithelial lesions, punctate lesions can be seen and needs topical antibiotics and lubricants and steroids in very in the late cases and in severe cases. So the take home message is itching and watering is not always allergy. High suspicion is required to arrive at a probable diagnosis and administer appropriate treatment. Counseling the parents is vital for understanding the nature of the disease and the complications, and ensures the compliance to the therapy. Thank you for patient hearing.
Thank you, Dr. Rupasri, for that comprehensive talk. I think we have around 5 minutes, and if anybody has questions, we'll be happy to take.
The allergen tests are available and affordable, and how much benefit it can give?
Allergen tests are available. Affordability, it is not so very costly, but as I told in my talk, it should be done, and as Dr. Rupashri also said, basically we need to find out the specific allergen. So usually the panel which in India they do know, they have the house mite, the gander, and also sometimes food allergy, depending on what type of pattern of allergy they have. If they have vernal, they do more of the dust and mites. If it is atopic, they also add on the food allergy also. So they are available, but they are available basically rural area it is a little difficult, but yes, in 2-tier cities also it is available. I think nowadays there is a subspecialty of immunologist as well as allergy specialists who do this, so it is available.
Thank you.
I think children who are going into chronicity, they should be done this, because most of the children, they do suffer. And one is, as she said, Dr. Rupash said, is take home counseling to the parents is very important, because intense rubbing, keratoconus, astigmatism increase is very common amongst children, especially if you ignore that. So you have to be extremely careful and keep talking to them. And most importantly, maybe those who are doing practice, make it a protocol. Do a topography at least once a year for children who have VKC. The incidence of keratoconus we are seeing a lot there, and especially with the advent of C3R, we can stop it very early. Dr. Malik?
Yes, we routinely do all the allergic patients in irrespective of their refractive error and K rating. Every year we do the topography. So in that way, we have found out many patients which are very early keratoconus and established keratoconus. Because of itching and watering, sometimes they are not. These are children. They don't complain of decreased vision and also. So we have to be very careful.
Also, the management of MGD, what the video they showed is, I think the most of you should have some sort of a videos to come educate the patients, because most of the time what I have seen is what we tell and what they do is totally different. So I think now with the smartphones available, all of you can download or have a video of your own. And to add to what Dr. Malik has shown in the video, instead of hands, you can use Johnson buds, because that they can be more focal, you can be pinpointed. Maybe you can ask them to sterilize those before you use. And also now you have special equipments like, for those eye masks. So you just either microwave it. Also you can use those thermostat electricity, wherein it reaches that particular temperature. What temperature we need for MGD treatment is around 45 to 48, less than 50, not more, not less. Because at that point only the mebum melts. So if you can use those newer, they are all available on Amazon also, cost less, but the compliance will be very high. So especially with people with chronic MGDs, acne and all those things, if you can use these newer modalities of lid hygiene, the compliance will be much better. There is one doctor, I think from LVP, he's developed that the original ones which microwave are all available, but AIOS. So you just plug it, it has a thermostat, it reaches 48, cuts off, and when it's below 45 again it switches on, so you can keep it. And the timing also, just keeping it, you have to keep it for 8 to 10 minutes. That is when the mebum starts melting, and when you give the massage, that is when you come out. And most important is monitoring. You have to see the clear liquid there in this one, and that is the end point.
Okay. Role of olopatadine in prevention of seasonal allergy. Any study on this?
Who will take?
Because I read somewhere.
Olopatadine, sir, it's a dual acting agent. It is a mast cell stabilizer as well as an antihistaminic. So it can be used as a prophylaxis for the prior to the beginning of the symptom. Whereas if you see chromal glycate, or they are only the mast cell stabilizer. It has no antihistaminic action. That's why it takes long. So olopatadine can be used as a because it's a dual acting. It can be used as a prophylaxis.
Because I have been trying olopatadine in children. I asked them to start it on 26 January and continue up to April and once daily. And if it continues for 2 years, then most of them, they don't get recurrence of spring catarrh at least.
You are speaking about vernal spring catarrh, sir.
Yeah.
Yes.
Ma'am, as you stated that the use of immunomodulators is coming earlier in the treatment of dry eyes, chronic allergies. So how do we present these treatment facilities to our patients who right now, in the time of internet and Google and everything, will definitely go into and ask me innumerable questions about the side effects of cyclosporine or tacrolimus. So how do you go about this?
Yeah, that's very pertinent, because especially kids, steroids means most of them gets, I think education is important. I think Dr. Pallavi will talk.
Sir, the topical immunomodulators which are available as for now are three. One we are using is the tacrolimus, the other one is the cyclosporin, and recently which has been introduced is a lifitegrast. So the safety profile of topical medications are okay, sir. They are already been published, and you can give them the literature which they only will bring and show to you. Only the 2% cyclosporin is an immunosuppressant, and that should not be, ideally either of it should not be used during pregnancy. So that is something which we should be telling them. Topical tacrolimus is known to cause a little sometimes recurrent chalazions, and some have irritation. So if you educate them the advantage of giving that, so what we do, I tell them is like it may give you a little later because it takes some time to act, but the steroid side effects have to be explained in form of raised pressures, occurrence of cataracts. Then the patients, more than patients, the parents are ready to take it because they are scared about complications. So we have to give them the whole spectrum, sir. Then they will accept the immunomodulators.
No, cyclosporin it doesn't have much complications. Only thing, yeah.
The only problem with the recently launched cyclosporin is that it's pretty costly.
Yeah, it's costly, yes. But the only thing what you have to think is don't prescribe cyclosporin which has a preservative. Many products have a BAK. So cyclosporin works, but the problem is with BAK because we have to give them for longer period, at least for 6 months or 1 year.
Indian products having BAK-free cyclosporin?
Yeah, it is a brand name you want to know? The Cyclomune, for example, it has a BAK. But the Sequa, how you use, sir? Sequa, how you tell the patient to use it?
Yeah, if you can economize it, of course
No,
the company will not say that. Maybe you can refrigerate it and use it instead of 1 day, 2 days. The cost will come down.
These uniums, one unium it can be used for 3 days. First thing I ask them, you have a refrigerator in your home. So you open the unium and ask them to don't touch the tip of the unium. Put 1 drop in the morning, put 1 drop in the evening, and this unium can serve for 3 days. Yes, and the 1 packet contains 10 uniums, so it will work for 30 days.
1600.
Okay. Yes, sir. It depends on the affordability of the patient. That's finally. Yeah.
Sir, 2 things about Sequa, not less a product. When they come as Nimmunes, they are preservative free. So when you are keeping it at room temperature, the chance of it getting contaminated and secondary infection has to be educated. So if it is a very hot and humid 40, 42, like that temperature, then the Sequa, keeping it open may not be a good idea. And regarding the cost, the Sequa drop which is there, it is a different formulation. Its bioavailability is good because, as we all know, cyclosporin is actually a hydrophobic. Because it's oil based. So the new drug that you are seeing, Sequa, is prepared like a Michelle, where the hydrophobic end is in the center and the hydrophilic is outside. So once it enters a tear film, its availability is good. That is why the cost comes. So that's if you can explain why you're using it, probably they'll understand. So temperature has to be maintained if you're giving it for 3-4 days.
Yeah, if they understand, if they're educated, and if refrigeration concept is understood, it will cost around 600-700 rupees per month. I think that should be okay.
When they come to know the effect of these drugs, anybody will buy. Even if they are not sound in financially, definitely they'll buy. Because nowadays these Sequa and all, they really are giving good
even the
research.
cyclomune, which is 0.1%, which is preservative free, it will cost around 500-600 or something. So, yeah. Nanotears, I think.
Nanotear, there are some other products in nanotears,
somewhere it will
hydro
cost
eyes.
100-200 this way, that way. So maybe you can take a call.
Yeah.
If you feel the patient won't be compliant, stick to the bottled ones. If they are compliant, maybe go to Sequa. If nothing, I think
we'll come to the conclude of this session. Thank you very much for patience hearing, and also I thank all the speakers for their wonderful talks. Thank you all.
Thank you.